Hello, everyone. This is Rebecca Cortez at CSH. We are about to get started. I just want to see if any of our panelists have called in and not been able to connect their phone line to their identification within the webinar. If you're there, would anyone who's a panelist let me know that you're on the line?
I think we're looking in particular for Alex.
And I am checking our list as well to just unmute people as they join by phone. Are any of the panelists there now on the phone?
Yes, Carol and Molly are
on. Okay. All right, I'll reach out to Alex, but in the meantime, I'll just go over the technology points for you all today. So we are recording the webinar. The recording has begun. Everyone is muted on entry to reduce background noise, but you can unmute if you've connected to the webinar by phone. Just use the red microphone to the right of your name on the participant list. If you have a question, feel free to click the chat button and send your message along to CSH Events, the host. If the question is about content specifically, you can send it to all panelists. If you're having audio trouble, go ahead and close the webinar window and relaunch the webinar. And if you're having any trouble accessing the recording or materials or just looking for that to come out, wait for it to come from our panelists in an email, or you can send an email to me at rebecca.cortez@csh.org, and I'll put that in the chat for you as well. The recording will be available within the next few days at the latest, but you can always reach out if you need some additional support before then. Sue?
Yes. Thank you, Rebecca. If we'll just keep waiting, if Alex doesn't join, we'll jump over Alex's presentation and go right to Molly and Carol. So thank you everyone for joining. This is a HRSA-funded technical assistance webinar with CSH, the National Healthcare for the Homeless, and the Fenway Institute as technical assistance providers. This is a national dissemination webinar. It's about youth experiencing homelessness who face a set of health and housing challenges. In particular, this group faces significant health disparities, higher rates of mental health and substance use conditions, but are at risk of underutilizing services and care. LGBTQ youth are at even higher risk for mental health and substance use conditions and make up a disproportionate amount of the population of youth experiencing homelessness. This webinar will explore the needs of youth experiencing homelessness with an emphasis on LGBTQ youth, best practices in providing care, and the intersection of behavioral health for this vulnerable population. See, do I have the ball? I do. See, Rebecca? Okay. So CSH is a national organization. We advance housing solutions to improve the lives of vulnerable people, maximize public and private resources, and build strong, healthy communities. We do that through training and education, policy reform, consulting and assistance, and lending. And the National LGBT Health Education Center is part of the Fenway Institute, and it provides healthcare organizations with educational programs, resources, and consultation. And its goal is to optimize quality, cost-effective healthcare for lesbian, gay, bisexual, and transgender people. Today's speakers, myself, Sue Augustus. I'm a Senior Program Manager with CSH. We hope to have Alex Curaglian, who's the Director of the Division of Education and Training at the Fenway Institute, Carol Ashbacher, who's a family nurse practitioner from Hennepin County Healthcare for the Homeless, and Molly Hoff, Clinic Supervisor, Hennepin County Healthcare for the Homeless. Our agenda today will be to look at the background and partnerships, the health center role and experience, and we're going to hear from the field from Hennepin County, and then we'll have time for questions and answers. So what does this population look like? Based on AHAR data, it looks like there's 50,235 unaccompanied or parenting youth experiencing homelessness in 2017. We've also found that unaccompanied youth are more likely to be unsheltered than adults experiencing homelessness. 22% of the healthcare for the homeless patients were aged 0 to 24 in 2015, so that's almost a quarter of the healthcare for the homeless patients were youth. 40% of the youth experiencing homelessness identify as LGBTQ, so it's a fairly large population. So there have been providers who have been working with youth for a few years, and they've identified certain needs and barriers. The youth population is hidden, so there's no perfect data source. In fact, even though I said there's 50,000 plus youth that have been counted, we feel like there may be many more that just haven't been counted because they're not as visible as the adult homeless population. They have challenges navigating healthcare and housing systems. Many of them don't come forward saying that they need housing or healthcare. Their histories of trauma means providers must practice trauma-informed care in order to engage with this population. There's a stigma with substance use that can cause individuals to not seek care. Perceived and real challenges as it relates to privacy and parental consent can be barriers to accessing healthcare and housing. And potential partners may not see youth as a priority because they don't come forward as much and because they don't use as much of the healthcare as adults do. So working with housing providers, it's really important that the housing providers use harm reduction principles, use trauma-informed care principles, that the supportive housing is non-time limited, so you don't want youth to be kicked out of the housing before they've had a chance to become self-sufficient or independent. And the housing provides a platform to access health care, for them to find employment, pursue education, and become independent. So there are national efforts that are focusing on the population of youth who are homeless. USICH has open doors, and ending youth homelessness is one of their principal strategies. They want to coordinate efforts across sectors, so it's important that child welfare, education, workforce, criminal justice, housing, healthcare, and the community are all working together to end youth homelessness. This is not one of those efforts that can be done by one single organization. It has to include a number of sectors to do it. There are national efforts underway. There's a HUD Youth Demonstration Project. HUD last year granted to 10 communities across the country to work on youth demonstration projects. These 10 communities have created plans, and we are learning a lot from them. As the community plans are underway, there will be a dissemination of many of the best practices and lessons learned from these 10 communities. HUD recently had a second round of the YHDP demonstration project. That's the Youth Homeless Demonstration Project. This time they'll select 11 communities. Of those 11, 5 will be from rural areas. And those communities will have until October to submit their plans for how they are going to use their grants. So again, there'll be a lot of best practices coming out of these soon to be 21 communities that are working on demonstration programs for youth. The efforts so far have identified 40,800 unaccompanied youth in those communities. They've discovered, not surprisingly, that there are siloed systems of care. So all those sectors we talked about before are very siloed, and that many of the service models have been designed for adults, and they just aren't that helpful when you're dealing with a youthful population. The opportunities, though, that are presented are integration of the youth as voices in the community, and it's really critically important that youth are given leadership roles and take leadership roles, and that youth are not thought of as second rate or second tier in the efforts in the community. They really need a community, coordinated community approach. Again, I can't say it enough that this has to be a collaborative effort with everyone in the community. And it's also providing a chance for the communities to innovate and to identify service models and ways to deal with youth that haven't been done before. So the foundational goals for the HUD Youth Demonstration Projects are to improve and understand data. Remember at the beginning we talked about how we're not sure that we have really quality data on the number of youth because they tend to be hidden. They want to understand the definitional and eligibility differences that exist between various systems. As many of you know, there are different definitions of homelessness, not only for adults but also for youth, so we have to figure out how that affects the numbers of homeless youth that we have. The goals also are to design and implement a variety of programs that work for youth with varying needs, again, because a lot of the programs were designed for adults, and also to coordinate with partners to leverage the necessary resources and knowledge, bringing in those other sectors that touch the youth population. So do we know whether Alex has joined us, Rebecca?
He still has not.
Okay. Then I think we will skip over Alex and go directly to Carol and Molly's presentation. Can you move the slides, Rebecca, to their presentation?
Yes.
I'm having trouble. Okay.
I can do that. I'm just checking to see what slide it starts on. Looks like it's on slide 40. All right, there we go. And Carol, I'm unmuting you now. And I will send you the presenter ball as well, Carol.
So we're going to hear from, we're going to hear from Hennepin County. So Carol and Molly will tell you about what they've been doing in Hennepin County, Minnesota.
Are you able to hear us?
We sure can.
All right, great. Well, hi, I'm Molly. I'm a public health nurse and clinic supervisor with Hennepin County Healthcare for the Homeless.
And Carol Ashbacher, nurse practitioner with the same program in Hennepin County.
Did you guys want to? Did you want us to hold off until you were able to advance the slides to where we start?
I'm sorry, what's the question?
I didn't catch what slide we start on in this.
Okay. I believe I will send it back to the right page, but it's slide 40 right here. Does this look correct?
Slide 40. Yep, perfect.
There we go.
Okay, thank you. Sorry about that. All right. So just a quick outline of what we're going to be talking about today. We're going to touch a little bit on how youth in Hennepin County do access our shelter, just to give people some context of where we're coming from. We're also going to talk about YouthLink, who's our community partner. Healthcare for the Homeless Hennepin County and YouthLink have a strong partnership. And then we're going to talk about that partnership, and then we're also going to talk about HCH's health services at YouthLink. So a little bit about how youth access shelter where we're from. So most of them access shelter through the Youth Services Network, which is an app, like a smartphone app and a website. All the beds ages 16 to 21 in Minnesota are on the app, and youth can just go on here, see what's open, and reserve a bed through the website or the app. This is an effort to reduce barriers for youth accessing shelter. We also have a coordinated entry system for adult beds, which are 18 and over in Hennepin County and in Minnesota, and that was started back in October of 2016. So the next slide shows kind of a couple of screenshots of what the app looks like, and then the slide before it's shown what the website looks like. And
okay, so this is Carol and overview of YouthLink. That we are not employees of YouthLink. We're just one of the partners. YouthLink targets ages 16 through 24. There's other agencies in the Minneapolis area that work with younger clients. YouthLink has been around for over 40 years. They don't have any specific shelter beds, but they do work with supportive permanent housing units. YouthLink became specifically an opportunity center and partnered with Hennepin County in 2011, but they have been working with partners before then. They have a drop-in model, which I'm going to a little bit more with the next slide. And their biggest event was opening up a 46-bed unit called Downtown View that is actually connected to the drop-in center, so that's changed some of their and the way they deliver services. Whoops, going back, not forward. Here. Okay, so the drop-in model focuses on meeting the youth where they're at. They are, it's totally voluntary program. When clients come in, they're required to have what they call an initial contact visit to explain services, to orient them to the drop-in center. They specifically use the word initial contact versus intake because they don't want, they're not looking at anything other than names, gender, pronoun preference, if they have any nicknames. They're not, they want the youth to know as well as their staff to know that this is the first visit that's going to start building that relationship. So it might be just 3 meals a day that they get, showers, washing clothes, and not access any other of the services because it's all voluntary programming. And it's oftentimes the YouthLink staff that are connected with the clients that will encourage the youth to come back to access clinic services. So it's their relationship that they've built, and they might see that someone has a cold or maybe an injury, and the youth had no intentions of coming into the clinic, but it's the co-location and then the soft handoff of the staff being able to introduce the youth to the clinic and get them to utilize the services. All right, so YouthLink very intentionally looked at how to approach youth, and they developed 9 guiding principles with Terra project. They worked with 6 nonprofit organizations that all worked with youth to develop their 9 guiding principles, and recognizing that there is a connection with the youth, that they all have faced adversity as well as trauma, but they're still unique, and so how to approach each youth in a unique way but maintaining these principles. And I'm actually going to advance a couple slides here so you can see the 9 guiding principles, bring in some of the points that were already mentioned in the presentation, but it's harm reduction, trauma-informed care, strength-based, wanting to approach, like I said, each person as an individual, and it gives a framework or a tone for the partners to be able to provide services, but also program planning for YouthLink to stick with these 9 principles. And going back, as I said, it's a principles-based, not rules-based, acknowledging that things can be fluid. It's hard to set a rule because there might be a situation where it can't always be applied, but they really want this incorporated into all their programming and the fabric of their agency. So Molly is going to talk a little bit more about the specific partners that YouthLink has.
So like Carol had mentioned, kind of giving that very brief overview of YouthLink's philosophy, and then also we talked earlier about how youth access shelter and services in Hennepin County. I wanted to highlight, since we're talking about partnerships today, how YouthLink decides what partners it's going to have in its drop-in. As Carol mentioned, it's a drop-in center model. So youth come and go as they need, as they please, and there's no program that they have to work. Everything is completely voluntary. So YouthLink uses those 9 guiding principles that Carol had mentioned as a framework to intentionally cultivate their partnerships. They want to ensure that the partners that they have for the youth share mission, share values, again, trauma-informed and harm reduction models. And so here's some examples on the slide of the partners that regularly spend time at YouthLink and serve youth in the drop-in space. I will say not all community organizations are a good fit for the drop-in model. You know, it can be kind of chaotic, youth meeting their friends, there's meals going on, and, you know, being that youth are youth, adults have to be willing to kind of go out and engage with the youth. So not all organizations work well in that framework, but the ones that do, it's really beneficial. And Hennepin County Healthcare for the Homeless is one of the partners brought in by YouthLink that has worked well in the space. We're not fully in the drop-in. We have separate clinic rooms just off the drop-in, but we have a drop-in clinic in the drop-in center, and it works really well for our youth. I just wanted to make a quick note. If you're looking to develop youth partnerships in your community, something that Hennepin County and YouthLink has done is formalize their partnership with a memorandum of understanding or an MOU. And essentially what it does is it lays out the relationship between Hennepin County and YouthLink or whatever community partner is signing it. It says what is expected of both. And the biggest thing with our partnership with YouthLink has been that we're co-located, but no money exchanges hands. So YouthLink doesn't charge us rent. We're a guest in their space. And Hennepin County doesn't charge YouthLink for providing their services to the youth. It's really just we have mutual goals. We both want to help the youth in the community, and this is how we're able to do it. Not every partnership needs kind of this formal legal document, but being that we are part of a government entity, it is something that we're required to have. The other thing that I want to highlight is that last bullet point that talks about the mutual goals of Hennepin County and YouthLink. And it says, it specifically calls out that we'll be intentional about consultation, collaboration, and communication between each other. And I think this is really important when you're developing a partnership, is you want to make sure that your philosophies align. If you have a harm reduction model and your community partner doesn't, that might be kind of a tough thing to navigate.
This is Carol again. I'm going to talk a little bit more about our clinic. It's 4 rooms. We have 2 that are could be set up as exam rooms, a lab, and then a flex room, which we use for health education, as well as we have a what we call a MNsure Navigator in Minnesota that helps people apply for medical assistance. We started out very small, only 8 hours a week. We had 2 4-hour clinics. We are now up to 30 hours per week. We are able to provide much more comprehensive care. I'd say the biggest impact I've noticed is we work a lot more with mental health and care coordination with more hours. Previously it was a pretty intensive clinic. We also have a nurse-run clinic that does some follow-up we have protocols set up to be able to treat STDs, and so there are some clinics that just have we call them nurse-run clinics. One of the challenges of being a partner was around communication. We started to do a release of information with every client that comes in, and we say it's for care coordination. We explicitly state we're not interested in sharing any specific health information. It's more about if they have an appointment and we want staff to help them remember it. Oftentimes, YouthLink staff know more details than we do about what's going on in their life. So with this ROI, I can go to a staff that they work with and say, I'm worried about this client. Can you keep an eye out for them? And that's all I need to say. They already know details around things. And so we update that annually. Quarterly partner meeting allows YouthLink to come back to us and tell us about the different partnerships that are available to clients. With their initial contact visit, they get oriented to everything, but youth don't always remember what's available, so it's good to know and remind them that there's legal aid services and GED, and even though they were told that, they might not remember it. So it's good to know what they're doing. The shared use of IT programs, YouthLink allowed us to access their database, not to their client notes, but we were able to see or to put messages in there, so we didn't have to always be calling YouthLink and saying, hey, have this client call us, but we were able to get into their system, put a message in, and then all the staff knew that the clinic was looking for them. YouthLink has their pictures up on their website, which was really valuable to us to be able to, for me, I can't remember people's names, so I can look up and see, put faces and names together, and that strengthened our partnership because I could get reminded of names and how to contact people, and that simple thing was very helpful to our program. And Molly's going to talk about our outreach.
So, like Carol had mentioned, you know, we've built this partnership, and it's one of the strongest in our Healthcare for the Homeless project. And that has definitely not been a success-only journey, and we've learned a lot about how to communicate. And one of the biggest ways that communication can be challenging between organizations that we've seen some success with has been through outreach. So youth don't often spontaneously decide that they want to go to the clinic. I mean, they have so many other things going on, so many other things are priorities that we really rely on YouthLink staff kind of borrowing on their relationships and their trust to kind of endorse us as a clinic. And one of the ways that they're really able to put this front and center is when we do outreach events, like we have it's called a Crush event here in Minnesota. It's a statewide annual rapid testing day for STIs. And this year we were able to test 62 youth in one day for STIs. And this required a lot of communication and a lot of coordination between clinic staff, housing staff, and YouthLink staff. And we were really able to come together and make sure that the event went smoothly. It was very well attended. And it helped that YouthLink staff were kind of able to endorse us through their relationships. Say, oh no, it's okay, you know, go and see Carol, she's really great and she can help you get tested if you're worried about it. A couple of other ways that we've been able to grow this partnership and do some outreach as a result is we're working on getting safer sex supplies into, we always have them available in our clinic hallway, but with the opening of this new housing, this downtown view that Carol mentioned earlier, we want to put some safer sex supplies in the housing so that the youth can access it whether the drop-in area is open or not. And so we're coordinating with YouthLink staff and our safer sex educator to find a way to have some supplies accessible in the housing. Another thing that we do with the help of YouthLink staff is flu and HPV shot clinics. So we'll table in the drop-in, and the YouthLink staff are really wonderful about saying, oh, I'll get a flu shot, and they'll do it as a demonstration for the youth, and then they're able to kind of bring youth over to our table. So again, kind of building those partnerships. We also do outreach outside of the building. There's an event called 5 to 10 Hennepin during the summer here in Hennepin County in downtown, and we partner with YouthLink as well as our Salvation Army Harbor Light Shelter here and Hennepin Theater Trust, and they have kind of a street carnival-like event that helps us to build community relations. It helps get our name out there, and we're able to table with YouthLink and, again, kind of cultivate those informal relationships. Looking at some of the opportunities that housing has brought into us. So Downtown View is that housing that was just built. The first youth started to move in February. They're a separate entity. The housing is a separate entity from the drop-in, but the proximity of it to the clinic provides us a chance to reach youth who maybe hadn't accessed the clinic before. We definitely have some opportunities, including finding new clients for the clinic that might not have accessed us before. We have every patient who comes into our clinic sign an ROI, and that extends to their service provider at Downtown View. So we are able to talk about a client if it's a mutual client. Again, we don't give, you know, much information other than, oh, hey, can you help this person remember this appointment? It also helps us with follow-up if we have a client who needs to come back for repeat testing or something like that. We are able to communicate that to the Downtown View staff, and they can kind of on that back end help encourage that youth to come in. We do all of this while being mindful of if we're being invasive with outreach. Youth have the right to privacy. Their apartments that they have, even though they're very close to the clinic, are their own apartments, and they're not obliged to engage with our services. They're not obliged to engage with any services provided in the drop-in. And so we just try to be really mindful of that and the opportunities that we have with this new housing, but also that youth are still youth and they have their own rights.
The video we were saying is optional based on time. I don't know if you, if the other presenters are available that you would not want to show the video right now.
Carol, how long is the video?
It's 3 minutes. There's a kind of a pledge at the end to Dr. Heather that I would stop when she comes on.
Okay, I think we have time. We also have a quick question I wanted to pose to you, and then we'll do the video. And I think Alex, our other presenter, is joining. So we'll do the question and then your video, and then we can have Alex, and hopefully we'll have a little bit of time at the end for questions. So the question to you, Carol and Molly, was, it was from Caitlin Bayer from Texas. She said, I like the idea of youth being able to use an app to reserve a bed. Who maintains the data on the app? Do you all end up having capacity issues due to over-reservation of beds? And is there any eligibility screening once a youth arrives at their reserved bed? So that's 3 questions.
So definitely there's capacity issues. There are times when all the beds are full, so that is an issue. The eligibility is age and as well as gender identity. So they you pull up the app and it might say 4 male beds or 2 female beds. So that becomes the only eligibility that I'm aware of. And then there was a 3rd question, maintaining data.
Yes, who maintains the data on the app? Who's in charge of it?
The social service agencies who are on the app with open beds or not open beds are in charge of updating their own availability.
Okay.
And the app was developed out of the Bridge for Youth in Crisis Technology Project. I'm not sure how long ago, but it was a couple of years ago, I think, at this point.
And if folks on the line have questions about more questions about the app or anything, could they contact you all directly? Or should they contact somebody else?
Yeah, they can contact us directly, and then also they can go on the website directly as well if they want to check it out. It's YSN as in Nancy, M as in Mary, N as in Nancy.org. YSNMN.org. I don't know if that link is on the slide that I made for it.
Okay.
I think it is. Yeah, but Youth Services Network, Minnesota.
Okay, I'll send that out to people in the chat. So let's see, what time are we? Maybe we should skip the video right now and go to Alex. Alex, are you on the phone?
I am. I'm so sorry, everybody.
Great.
I'm at a site visit in New York City, and things got mixed up, but
no problem.
Very glad to be here.
So thank you, Molly and Carol. I think in the interest of time, we'll skip your video. Hopefully we can show it at the end. And maybe we can also tag it on with the slides if that's possible. So Alex, we're going to send it over to you. And Rebecca, can you, or I can give him the ball. He has the ball now. So let's go back to your slides, Alex.
I'm going to the slide now. I believe it's 15.
Wonderful.
Mm-hmm.
Okay.
All right.
Thank you, Alex.
Great. So should I move it to my slides, or is someone else doing that?
Rebecca is supposed to be doing that for you.
Okay, I won't touch it then.
Do you want to introduce yourself and Fenway?
Sure, will do. Hi, everybody. This is Alex Groglian. I'm a psychiatrist at Fenway Health and director of the National LGBT Health Education Center at the Fenway Institute, which provides training and technical assistance to health centers to improve the quality of care for LGBTQ people. As a psychiatrist, I focus a lot on behavioral health and behavioral health care as well, and we've done a lot of work with folks experiencing homelessness and the National Healthcare for the Homeless Council, and are enjoying our partnership with CSH very much. So I'll be discussing health disparities, barriers to care, and best practices in meeting the needs of youth experiencing homelessness at health centers, as well as a specific focus on LGBTQ youth. First, focusing for a couple of minutes on the range of health disparities and barriers to care faced by youth experiencing homelessness. Certainly, most of these fall into what we would consider social determinants of health, factors in society that down the road lead to adverse health outcomes for these youth, and some of that is by way of mental health problems, behavioral health problems that can develop. Obviously, there's extensive social isolation in many circumstances involving youth experiencing homelessness, various challenges remaining in educational programming or in employment as a result of the psychosocial chaos and lack of stability that facilitate that kind of engagement in school or work. Extensive violent victimization, unfortunately, incurred at a much higher prevalence among youth experiencing homelessness than their more stably housed counterparts. survival sex, again, at a much higher prevalence as a way to make it through and survive. We use a minority stress framework often to understand this, and I'll talk about that in a minute for LGBTQ youth specifically, but it's true more broadly that in the context of various social determinants of health that are significant challenges, these youth have a much youth who aren't even necessarily LGBTQ identified, but experiencing homelessness, have a much higher prevalence of depressive disorders, including major depressive disorder, various adjustment disorders, anxiety disorders, including panic attacks, generalized anxiety disorder, social anxiety, post-traumatic stress disorder, often in the context of repeated traumas that aren't just related to one index traumatic event, but multiple experiences, and then substance use disorders as a way to cope with all this stress, and often interconnected very directly with post-traumatic stress disorder, a way to numb and avoid cognitively and emotionally processing the pain. This is a framework we use to understand behavioral health disparities among LGBTQ people. Generally, external stigma-related stress, victimization, discrimination, microaggressions, frank violence can lead to disruptions in general psychological processes like cognitive structures, believing it's never going to get better, nobody can be trusted, no one will ever love you, interpersonal functioning, emotional regulation can be difficult, coping mechanisms can be impaired, and then internal stigma-related stress, internalized homophobia, internalized transphobia, all this stress over time related to one's minority identity, sexual orientation or gender identity, leads to what we observe in the literature, which is a much higher prevalence of behavioral health problems among LGBTQ youth, decreased self-care, decreased engagement in healthcare and at health centers, and down the road, a much higher prevalence of physical health problems among LGBTQ youth. So what are some best practices for meeting the health needs of youth experiencing homelessness with a bit of a focus on LGBTQ youth as well, given that 40% of youth experiencing homelessness in the U.S. are LGBTQ identified. So if we're talking about homeless youth in the U.S., their needs, and not talking about LGBTQ youth, we're missing a big part of the conversation. The first big part of this for all youth experiencing homelessness is creating a trauma-informed care environment. SAMHSA defines trauma-informed service organizations as ones that realize the widespread impact of trauma, understand the various potential paths for recovery, recognize signs and symptoms of trauma in clients, staff, and others involved with the system. The service organization has to respond by fully integrating knowledge about trauma into policies, procedures, and practices, and has to seek to actively resist re-traumatization for clients, staff, and anyone else who interacts with the system. Trauma-informed care has emerged as a national priority in the context of several evidence-informed treatments that are designed to improve post-traumatic stress symptoms that have emerged. Implementing these evidence-informed approaches, unfortunately, has been inconsistent at health centers. It's been difficult to get staff who are trained in systems that are designed to deliver these interventions. The issue has gained more attention recently in the context of veterans returning from combat with post-traumatic stress, so we're seeing more of an openness and readiness to implement these evidence-informed interventions. A trauma-informed approach in general, and certainly for youth experiencing homelessness, should incorporate the following elements: a trauma-sensitive practice environment, so all staff, clinical and administrative, are trained to know how to create a sense of safety in all patient interactions. We need to identify trauma and its mediators, so factors that contribute to trauma, like minority stress, for example, among sexual and gender minority youth, the consequences of post-traumatic stress, including poor adherence to treatment and high-risk behaviors, like high-risk sexual behaviors or substance use, which can predispose to a variety of things, including HIV infection, which is also more prevalent among homeless youth. Educating patients about the connection between their traumatic experiences and negative behavioral and physical health outcomes, which often isn't obvious for folks to see, particularly youth who can be very concrete in their thinking. In linkage to appropriate referrals and resources for more specialized treatment, this can include specialized services for homeless youth and for LGBTQ youth generally. The SAMHSA National Center for Trauma-Informed Care is an excellent online resource. I encourage all of you to refer to it. It advises promoting awareness and implementation of best practices nationally. The center is tasked and mandated with disseminating resources and referrals for trauma-focused treatment. So you'll find regional referrals as well, depending on where you're locating. And the idea is to have a flexible approach, organizational approach rooted in general principles that focus on being mindful of and responding to people who've experienced trauma or may be at risk for trauma, rather than a very rigid set of procedures that everyone would be expected to implement. So the name of the game is flexibility. Community addictions treatment settings are now more open to a trauma-informed care approach, integrating treatments that are for dual diagnosis, co-occurring substance use disorders, and post-traumatic stress. These kinds of interventions that target both have been found to be well tolerated and improve both substance use disorders and PTSD among youth. For example, cognitive behavioral therapy for substance use disorders is a protocol developed by Carroll for addictions, including alcohol use disorders and cocaine, focuses on coping with cravings, shoring up motivation and commitment to reduce at-risk substance use, refusal skills and assertiveness training, which can be really important for youth, particularly youth engaged in survival sex, for example, developing an all-purpose coping plan that's personalized, and HIV risk reduction. Another evidence-informed intervention is cognitive processing therapy for PTSD, developed by Patty Resnick. This involves education about post-traumatic stress, writing an impact statement to help understand how the traumatic experiences influenced person's beliefs about themselves, other people, and the world around them. And it focuses on decreasing avoidance and increasing resilient coping. And part of decreasing avoidance is encouraging connection to community and other youth, which can be so critical for youth experiencing homelessness, and particularly LGBTQ youth experiencing homelessness. This is the cognitive triad of trauma, which I think about all the time when working with youth experiencing homelessness. Trauma can distort people's views about the world. So people start to believe the world is a dangerous place. People can't be trusted. Life is unpredictable. Distorts views about the self. I'm incompetent. I should have reacted differently. Too much for me to handle. I feel damaged. And views about the future. Things like things will never be the same. What's the point? I'll never get over this. It is hopeless. So we want to restructure those maladaptive cognitions. We want to create safe communities and spaces, encourage clients to use peer support resources that are either online or in person, community organizations dedicated to affirming youth, including sexual and gender minority youth, and provide advocacy within public mental health systems for youth residents of group homes and homeless shelters, which often aren't designed, for example, to room transgender youth based on their gender identity. These youth are often still forced into quarters based on their sex assigned at birth, which can be an even higher risk factor for assault. We want to promote a sense of safety, understand how prior traumatic experiences influence the reactions that these youth are going to have, like in the process of seeking care. They're going to be mistrusting in many cases. And that kind of interpersonal trauma can perpetuate mistrust of caretakers and increase the likelihood of being re-traumatized very easily, unfortunately. In order to retain homeless youth in services at health centers and with supportive housing, we need to understand how trauma histories require us to engage in a collaborative way with transparency, with trust, and to consistently communicate supportiveness. We need to screen all patients for a trauma history with real attentiveness to subpopulation with higher risk, particularly youth experiencing homelessness and LGBTQ youth, and screen for intimate partner violence, which is going to be very common in this population. If trauma is identified, traumatic experiences are identified, we need to screen for actual post-traumatic stress symptoms. This is the primary care PTSD screen that SAMHSA recommends. You can find this on the National Center for Trauma-Informed Care website. This is a screener specifically for intimate partner violence, again on the SAMHSA National Center for Trauma-Informed Care website. And then you want to use, if people have past traumatic experiences based on those screens, something like the PTSD checklist to identify whether they have active PTSD symptoms. Again, all on the SAMHSA Trauma-Informed Care Center website. We want to build resilience among these youth. This is how SAMHSA defines resilience. The term refers to the ability to bounce back or rise above adversity as an individual, family, community, or provider, well beyond characteristics of hardiness. Resilience includes the process of using available resources to negotiate hardship and or the consequences of adverse events. Really critical for youth experiencing homelessness is behavioral health integration, which comes in three forms. There's a spectrum of how integrated a setting can be. There's coordinated care with minimal collaboration or basic collaboration at a distance between behavioral health and primary medical care. There's co-located care, basic collaboration at the same site. Close collaboration is level 4 with some system integration. And then finally, truly integrated care Level 5 is close collaboration approaching an integrated practice. Level 6 is full collaboration in a fully transformed, emerged, integrated practice with behavioral health and primary medical care as part of very much the same team. One example of collaborative care that's critical for youth experiencing homelessness or of behavioral health integration is collaborative care, an evidence-based model for depression and anxiety, where care managers monitor symptoms with standard measures, who advise patients on how to self-manage anxiety and depression. As needed, primary care providers will contact behavioral health specialists who will advise on how to use established treatment protocols. And it's a stepped care approach where patients who don't improve at one level of care are moved up to more intensive levels of treatment, or there are adjustments in the psychotherapy or the psychopharmacology, the medications. One specific evidence-based model for this is IMPACT, Improving Mood, Promoting Access to Collaborative Treatment, developed at the University of Washington. Principles are population-based care, measurement-based care, and integrating psychiatry and primary care. So there's collaborative care in primary care with a depression care manager who pretty much runs the show. The initial treatment plan is developed with a psychiatrist who identifies the medication regimen, psychotherapy, and then it's really the depression care manager and the primary care provider who conduct treatment. And you measure outcomes like a PHQ-9 for depression. If after 6 or 8 weeks the PHQ-9 scores haven't dropped by, say, 50%, then the psychiatrist would come in, adjust the treatment plan, adjust the medications, the therapy, psychotherapy would be adjusted as well. And this has been found to be very effective at improving depression. Similarly, we know very high prevalence of substance use disorders among youth experiencing homelessness and LGBTQ youth. So another form of behavioral health integration in primary care for health centers is screening, brief intervention, and referral to treatment, ESPERT, evidence-based practice to identify, reduce, and prevent problematic substance use in primary care. So you would screen, staff would be trained to conduct a brief intervention rooted in motivational enhancement principles, and then refer to appropriate addictions treatment from there. All right, thank you for your time. We have 10 minutes or so for questions and discussion.
Wow, Alex, thank you so much for all that really great information. We did have a question in the chat that I wanted to ask before I forget, and I think it was addressed to Molly and Carol, but certainly, Alex, you can chime in as well. It was a question about dealing with youth under 18. How do you deal with parental guardian consent for those under 18? So Molly and Carol, how do you deal with that? If you're still on, you might be on mute.
Okay.
Can't hear. There you go.
Okay. In the state of Minnesota, there's a statute specifically addressing homeless youth and stating that if a minor is living apart from their parent and managing their own finances, they can consent for their own medical, mental, or dental care, and regardless of what those finances are. So in the state of Minnesota, we have that, they can give consent.
And is that a fairly recent change in the statute, or do you know anything about the history of that?
I don't know the history of it. I don't think it is, I don't know the date of it, but it's been in existence for several years. There hasn't been anything updated that I'm aware of. I have at least since 2013, I have printed out the statute, and it might be even longer. My guess is longer, but I don't know the exact date.
Okay, I know that this question is very state specific, so everyone on the line should understand what their state statute says about youth giving consent both for medical treatment as well as whether they can enter into a contract if they're under the age of 21 or 18. So check your states to see what's going on. It could be an advocacy point for those of you who have very strict state statutes. Alex, did you have anything to add to that?
No, I thought that was pretty comprehensive. While we're on the topic of LGBTQ youth in this situation as well, one thing we often run into with youth experiencing homelessness who are estranged from their families are complications related to the fact that in order to initiate gender-affirming hormone therapy among adolescents or minors experiencing homelessness, if there are any legal guardians, you have to have permission you have to have consent from the legal guardians in order to initiate gender-affirming hormone therapy, which can lead to a lot of problems. And even if there's one parent, for example, who is consenting, and there's another parent who's a legal guardian but isn't particularly in the picture and isn't consenting, we're unable to move forward with gender-affirming hormone therapy. So this is the kind of challenge we unfortunately run into.
Oh, great point. Thank you. So I think Rebecca has unmuted most of you, or she can do that if you have, let's see, a question. We do have another one in the chat, though, which is any ideas on how to build rapport with youth in a medical setting that does not have a youth drop-in center? The questioner says, we do have patient navigators who can leave the clinic and meet youth in the field. So Molly, Carol, or Alex?
I think approach slowly. Trauma-informed care is a good basis. You know, watch the cues of the client. There are times when on an initial visit, I might not have any physical exam because I can tell the client is just not ready for that. So I think that's how I would start the relationship. Being non-judgmental, honest. If you don't understand something, if terms are used that I don't know, I just come right out and say it, and it's a way of starting the relationship.
Thank you. Alex, do you have any thoughts on that?
Yeah, I think you want to demedicalize your approach as much as possible in terms of how you engage them. You want to meet youth where they're at, use language that is the kind of language that youth would use, reflect back the terms that they use with them. One helpful tip for trans youth is to, for example, for body parts, use the terms that they use rather than using gendered terms for their anatomy when doing a physical exam. So we might ask people, explain that we're doing it. This is part of the trauma-informed approach as well. We might ask folks how they refer to the part of their body that we're doing a physical exam on. A lot of transmasculine people don't refer to their chest as breasts, may not refer to what we would call their vagina as a vagina. They may refer to it as a front hole, for example. So you want to ask people what terms they use, because if we use these very gendered terms for anatomy, it can sort of lead to increased gender dysphoria among youth. So we want to be sensitive in that regard, and that's an important way to engage trans youth. The other thing is to ask all youth for their name and pronouns. What's your name? What are your pronouns? So the most effective way of causing youth to not return for care is to misgender them and use the wrong pronouns. So asking people what the name and pronouns are, and then reflecting that back and making sure everyone else within the setting is also up to speed on what that young person's name and pronouns are, will go a very long way.
Great, thank you. We have a couple minutes. Does anyone want to ask a question over the telephone? We still have a minute or so to ask these really experts in the field a question about youth and their healthcare needs, how to approach them. Do we have time to show the video for those of you who can stay on? Rebecca, can we go a minute over for people?
Sure. Yes, I'll start it now.
Great. Thank you so much to our presenters. Molly and Carol, if you can stay on for another minute or so, we'll show the video.
Sure.
Great. Thanks, everybody, for joining. So here's the video.
My name is Angel Sandro, and I work at YouthLink as a youth lead advocate, and I also do street outreach. YouthLink serves at-risk and homeless youth. Our mission here at YouthLink is to serve youth by investing in their education and investing in their employment. Part of my passion here at YouthLink is to build relationships with young people. Without building that relationship, you're not going to be able to know what the youth needs in their life. Here's a story of a young man that YouthLink has served.
I was really homeless when I was 14. My mom kicked me out, and like my dad's been homeless since he was 16 when his dad died. My dad got released from prison, and like I met him, you feel me? And after I met him, I just got introduced to like the wrong side of town, this east side, around a whole bunch of people that just drink, smoke, party all day, barely go to sleep. The reason I dropped out when I was 16 is basically because why the hell should I come to school if a teacher's telling me and the counselor is telling me, like, even if I try my best and do everything I'm supposed to and try to turn this around, that it ain't gonna work. So I just stopped going. Basically discovered YouthLink through like Studio 4. I was with Paris Yard. She introduced me to this application, Nicholas Square, and I ended up getting accepted to the application and moving in the building. I don't like music. I love music. It helped me, and it helped me get off the street. I feel more safe. I feel like I ain't got to be outside all day, every day. I started working at Butter Bakery. You know, I'm back on the payroll. I get a consistent paycheck. I got something to look forward to doing. I'm not just out BSing or going to chill with my friends. I like it, you know what I mean? And it's really helping me get another chance and looking at life and keep moving on forward. Because a lot of people try to lace you. A lot of people want to see a young, talented young man that look good not do good. And when you're around a lot of wrong people, they just want to bring you down to, especially adults. So like with our youth and me really seeing, like, get away from that and leave that alone and stay and do this, I would probably be just like that. Youth and just changed it dramatically, man. They saved my life.
Hello, my name is Heather Huseby, and I have the pleasure of being Executive Director of YouthLink.
And here's
the story you just heard is one of 1,000 stories that we see at YouthLink.
Thank you, Carol and Molly.
In the state of Minnesota, every night there are 4,000 young people who are homeless. At YouthLink, we know that young people who are homeless are on a journey. And homelessness is just a stop in that journey. It's not their destination. What we want to do is to help youth get back on their pathways of opportunity towards jobs, education, and housing stability. We want to thank you, our supporters, our friends, and those who make a commitment to help youth to get back into.
All right. Thank you, Rebecca. Again, thanks to our presenters. Thank you all for hanging on for a couple extra minutes. If you have questions or need any more information, please feel free to contact me or any of the presenters on the line. So thank you very much. We hope you'll join us for our Learning Collaborative. Our second one will start sometime late summer. So thanks.